Yes, sir.
Yeah. Okay. Can you see it?
Yes, sir. Yes, sir. Slideshow, sir. Slideshow.
Okay. Thanks again to both of you, Dr. Chandrasekhar and Revati. I mean, this is an important area, the cluster postoperative endophthalmitis, because an incident like this can really affect any organization, the sustainability and stability of the organization or a private practice. So it's important that we avoid such a situation in our practice. If you look at the end of the postoperative endophthalmitis, it could be sporadic or a cluster, or it is also called as outbreak when you have a group of cases. So when you come to the sporadic endophthalmitis, they are very different. So the sporadic endophthalmitis, which we see on and off, there are very few cases, can be separated from time to time, and usually occur very irregularly, haphazardly, and it's usually very infrequent thing. And you cannot connect two cases of endophthalmitis to any single cause. And they also show very little connection with each other or a recognizable common source of infection in case of a sporadic endophthalmitis. And often the organisms which cause sporadic endophthalmitis are gram-positive organism, and usually the gram-negative is around 20% or less. And there are with a lesser incidence of fungal being the cause of sporadic endophthalmitis. And they are usually mild, and it is usually easy to manage these patients. Whereas the cluster endophthalmitis is defined when you have two or more cases of endophthalmitis occurring on a particular day, especially in a single operating room operated by one or more surgeons. Or it can also occur over a short time interval due to a common cause in the OT complex over a period of time. And it is when you have cluster, it is usually bacterial, and very often it is gram-negative, rarely fungal. When this fungal endophthalmitis occurs when the cases are separated by a time period. No, it occurs over a period of time, not on the same day. When it occurs on the same day, it is usually bacterial, and it is gram-negative. And the cluster endophthalmitis, as I mentioned, it is usually very acute, and it occurs between 24 to 72 hours in most of the cases. Either the signs and symptoms, both are very profound. The pain will be very severe. Diagnostic criteria for endophthalmitis, and the patients will have very profound visual loss, whether it is congestion, chemosis, lid edema, or anti-Cheber reaction or hypopia. They are all very profound. And in sporadic endophthalmitis, the culture positivity is somewhere around 25 to 30% in most institutions, whereas in a cluster endophthalmitis, it can be anywhere between 80 to 100%. So both the vitreous and the aqueous grow the organism in cluster. So that's a major difference. And I just would like to highlight this cluster endophthalmitis. It happens often, and it gets reported in the media. The year 2008, there were 11 instances, and about 165 cases were reported. This is from a government communication. So wherein they also, as per the government communication, they also have isolated the organism from finger lactate and viscoelastic, and there was also a directive at that time that we autoclave all solutions, including the viscoelastics. And in the year again, there was in 2014-15, there were one or two instances. So the government had collected all the instances and reported about 9 instances which happened, which are brought to the government notice, and wherein about 204 of the 527 patients operated in 9 instances had endophthalmitis. So they occurred in different places in the country. So this happens every year, at least several times. Even recently, we had 2 episodes of endophthalmitis which were reported nationally. And if you look at the predisposing factors in all these instances which have been reported, they have either pointed it towards deficiency in sterilization or contaminated irrigating solutions or viscoelastics. As you can see in this picture, you can see a kind of a coagulum of fungal ball in this bottle. No, so unless you really monitor these things on a regular basis, you may not be able to pick it up. Or it could be due to contamination of the internal tubings and the phacoemulsification. And the the operation room hygiene and also contamination of the ventilation system also can play a role. So I'll just share some my personal experience with a few cluster endophthalmitis. This is talking about one cluster of 8 cases. All happened on one OT, where 18 patients were operated on a single day by 2 surgeons. One surgeon operated 17 patients, the other surgeon operated 1 patient. So the first 5 patients of the 18 were phaco, the rest 13 were small incisions. So all of them were uncomplicated, no PCR or any need for vitrectomy in this group of patients. On the subsequent day, the second day, during the postoperative period, 1 patient was seen to have developed postoperative endophthalmitis. This patient was seen on the morning. The patient was held back for uveitis, and the next day he presented with endophthalmitis. And second patient came in the evening with feature suggestive of endophthalmitis. So there are 2 patients. Hence, the rest of the 18 patients were called. And then what we found was the first 4 patients who had a phacoemulsification had developed endophthalmitis, and there was no sign of infection in the 5th patient who again had a phacoemulsification. Among the small incision cataract surgery, the first 4 patients had developed. So all were pseudomonas endophthalmitis. So this is the sequence of the 18. The first 4 who had a phaco had endophthalmitis. The 5th there was no endophthalmitis, and again the next 4. So usually we operate on 2 tables, and both the tables the patients had endophthalmitis. And of this, about 3 patients had poor outcome. So when we looked at the possible cause, on a particular day, 8 sets of instruments were used. So which means these 8 sets of instruments were autoclaved, which had undergone a long cycle autoclaving the previous day. So only the patients where we had used the fresh sets had developed endophthalmitis. So the 8 sets, 4 were meant for phaco. So those 4, the first 4 developed endophthalmitis. Then the 5th case was operated by a set of the same instruments, but they were autoclaved. They underwent flash autoclaving, and it was in the same trolley. The trolley was not changed, but only the instruments were autoclaved and brought back, and they were used. And that particular patient did not develop it. Then subsequently, the next 4 cases were operated with the instruments that were meant for SAC. So there was some deficiency in the long cycle autoclaving that was done on the previous day. So that was the clue. So what is the lesson we learned from it? That is, the documentation is very important. The indicator we use for documentation is very important. So we were using this class 1 indicators. So this class 1 indicator, even with the minimal change in the temperature, the indicator tape can change, and it does not indicate the pressure. So that was the time we also switched over to class 5 indicators, where you need both the temperature at a certain level and also the pressure. So now, as a result of this incident, we switched over to this, and whether it is a long cycle or a short cycle, this indicator is used for every load or every bin it is used. So this is one important lesson we learned. The second is the involvement of the OT staff. The particular day when this incident happened, the staff were not very happy about the bin. So when a set of instruments all have undergone a full cycle autoclaving, they really have the feel of the towel and the instruments, all of that, which was missing in this case, even though the sterilization marks were appropriate. So because of the assurance given by the CSST staff, they autoclaved it. So from that point, any doubt we have, we kind of resorted to re-sterilization. At least I personally at least on 3 or 4 occasions where we had a doubt, we were not very sure because the printout was not clear, or some one indicator is not changed, so we had re-sterilized it. And again, this also enforced the belief that cleaning and autoclaving instruments between surgeries is effective. And we can, even though we had the same instruments were placed in that particular trolley, but when we use the same, nothing happened. So which also shows that the clean autoclaved sterile instruments is more important than anything else. So that's the first thing. The second is a cluster of 12 cases which had endophthalmitis. That was all operated by one single surgeon. He operated 24 cases in the same OT. There are 8 cases he had operated phaco, and then followed by about 16 cases of manual SACS. Of this, one patient had a PCR and also had anterior vitrectomy using the same machine. So if you look at the course of events, the first case was seen on the second day, the second case was seen on the third day. So based on that, all patients were called back. All 24 patients were called back, and 10 of them showed early signs. In addition to this, 10 of them showed very early to establish postoperative endophthalmitis, and many patients were reluctant to come, saying that they are doing well. When we called them and we found them, they had early signs of endophthalmitis. And giving an intravitreal antibiotic at that point of time was very useful. So that, and of all the cases which were operated, the 8 patients who had phacoemulsification and the 4 patients who had a small incision developed acute endophthalmitis. The 8 of them underwent vitrectomy, and 4 patients were given intravitreal antibiotic. And there was no need to, none of the patients went for phthisis or no PL. They had a poor visual recovery, less than 5/60 in 3 cases. Rest of the patients had 6/60 or better. And the possible cause, we were able to culture the same pseudomonas which we cultured from the vitreous, also from the internal phacotubing. So with a similar antibiotic sensitivity pattern, which we feel could be the cause. So whatever there was contamination, this happened long time back, like 15 years back, when this used to be a problem. So one of the small incision cataract patient had a vitrectomy using the same machine, also had developed endophthalmitis. We feel the other 3 patients who had small incision patients who had this, also in some way the doctor had used the IA unit of the machine for removing the lens material. So all of the patients wherein we had used the phaco machines had endophthalmitis. So this could be, possibly this could be due to, that was a time when we used to clean and reuse the phacotubing. Okay, so this could be possibly that there could have been leftover water, that the tubing were not completely dry. They were not, the cleaning was not appropriate, and this, which means you may not, this ETO may not properly sterilize such tubing. So, or it could be due to the contaminated internal tubing which should have caused this. So we were not very sure either of this could have happened in this particular case. So one of the important lessons we learned in this is that ensuring that we recall of the patients. Some patients who were not willing to come, we sent our own vehicles to pick them back and bring them to the hospital, or examine them there and bring them. And it is important that we ensure everyone is re-examined in spite of their subjective status. And that is also the point when we stopped reusing the disposable tubings that cannot be autoclaved. If the disposable tubing, if a tubing has to be, only we started now, wherever we were using reusable tubing that can be autoclaved, we used them. If it has to be ETO'd, then we gave it away. We also understood the importance of cleaning and drying of the tubings. Still, some of the retina tubing reusables are all used. So we really make sure that people are well trained to do this part. And again, there could be a possibility of mixing of unsterile item on that particular day. So segregation also was given a lot of importance. So these are some of the lessons we have learned from this particular episode. And I also would like to share with you a cluster which occurred over a period of time, which we had to handle. So this is initially there were 2 or 3 patients who were seen, but subsequently over a period of 3 months, 12 more cases of endophthalmitis were seen by us. And all of the patients were operated at the same hospital, but they were all operated by different surgeons. As you can see, the average time of presentation varied anywhere between 12 days to 90 days. So this was the case. And these are cases are very difficult to understand. So all of them had undergone phacoemulsification. Some cases presented with uveitis, some had hypopion, some of them had only without any hypopion, they had vitreous. Some patients presented with infiltrates in the corneal wound. So there was a varying presentation, and we were very confused with this particular presentation of cases. And we had a detailed microbiological investigations of the whole system of that particular hospital was done by our team, which Dr. Lalita will present, share in a presentation, because it's a very detailed thing. She will cover it as part of the root cause analysis, and there's a lot of learning for all of us from that incident. So, I mean, if you look into the literature, there are several articles that have been published on cluster endophthalmitis. Here, they've reported Pseudomonas aeruginosa endophthalmitis caused by contamination of the internal pathways of the phacoemulsifier. There is a paper that talks about trypan blue being contaminated and used. These were all compounded trypan blue in the early days, which when it was not available, they were all made in the local pharmacies. Similarly, there is a report from Turkey wherein they talk about irrigation solution being the cause, where they were able to isolate the Pseudomonas aeruginosa. And Pseudomonas is a very common contaminant. So this is where it is really important not to use tap water in our operating room. It's always better that we use RO water. Now make sure that all your hand cleaning, washing, instruments. We also use additional filter, wherein we really get a pharmacy quality, injection quality water, which we use for cleaning the instruments. All of that have made a big change, a tremendous change in bringing down the endophthalmitis in our setup. So to summarize, the cluster infections are always infective, and it is always possible to find the source. The sad thing is when we look into those the reports I earlier showed, the 2008 and 2014-15, even though they've described the number of cases and what happened to them, they were not able to find the cause. Why this happened? One is there is a lack of methodical investigation. Other one is not following standardized protocol and not having a standardized way of documentation. So only when you have this, even when something goes wrong, you'll be able to find it. Otherwise, it will be very difficult to find what could have caused this infection. So this is in brief what I would like to share with all of you. Thank you.